I think I'll take you through this topic of approach to a patient with obesity and how it is different from what is mentioned in the guidelines as compared to what we actually do in clinical practice. So I'm sure all of us here are well aware that obesity is a big problem globally, and it has reached pandemic proportions, more so after COVID, where again, people have gained a lot of weight. When you talk of data from Sri Lanka, we see that about 50% of women and about 30% of men are obese and overweight, and this is from the World Obesity Federation. But what the World Obesity Federation has very interestingly done is, for each and every country in the world, they have come up with something called as a risk score. They've come up with the national obesity risk, and they've come up with a childhood obesity risk. And this is just not based on prevalence. This is based on the kind of infrastructure that is available. It is based on the kind of projections that go on as to how the obesity rates will increase in any given country. And for Sri Lanka, it is 6.5 on 10 for the national obesity risk, and about 5 out of 11 for childhood obesity risk. Now, how does it compare to other countries? Yes, it is definitely high and very similar to what statistics we have from India. So it's 6.5 on 10 for the national obesity risk in Sri Lanka. When you compare to India, it's 7 on 10. The childhood obesity risk slightly lower, 4 out of 11. But yes, I think our part of the world, our regions in South Asia are really battling this pandemic of obesity, which is a big problem. This is a very recent paper actually published last week from our group looking at the National Family Health Survey data. And again, we are seeing that about 40 to 45% of our population in India is also overweight and obese. So how do we manage obesity? Well, all of us as physicians need to know that. The time will come, or the time is already there, where patients walk into our clinic and talk to us, "Doctor, I want to lose weight." That is their presenting complaint. That is a problem that they seek treatment for. So all of us as physicians should be apt to handle this pandemic. And when you look at guidelines that are available to manage obesity, going back from the American Obesity Society guidelines that came in 2014 to what's available as of today, the guidelines have changed slightly. What used to be just a BMI-centric approach, wherein patients, the guidelines would just say that, you do this and this much of BMI would come down, that has changed over. And we're no longer looking at just numbers. We're looking at patients as a whole. We're looking at their complications. We're trying to address the quality of life of patients with obesity, rather than just looking at, okay, 5 kgs less is better than 4 kgs less, and that's out of the picture. From India, we've got 2 guidelines in the last 1 year, one by the Endocrine Society of India and the other by the Research Scientific Society of Diabetes in India, 2 big organizations, and both of them have addressed obesity in a very similar way, and that's what I would present to you, and that is something that was actually adapted by the Canadian Obesity Network, a simple framework called the 5A framework that all of us can use in our clinical practice and apply to patients, and we can help them lose weight. So I'll take you through this framework in the next 15 minutes or so and see how it is helpful. So what is the 5A framework? Let's start with the first A. The first A is ask. And I think no guideline otherwise would mention, this is an important question, but I think the first thing that we need to ask our patient who walks into our clinic for obesity management is whether that patient is willing to lose weight or not. Now, sometimes this patient is a child brought by a parent, sometimes it's a spouse brought by a husband or wife, sometimes it's a relative, a sibling. But if the patient who's really having this problem with obesity, and if that patient is not willing to lose weight, then it's going to be your entire duration that you're going to spend with the patient will not be very fruitful. So you need to make sure that your patient is willing to lose weight. If yes, you proceed. If not, you tell them that yes, there are options available, and when you think it's important, you should come back, but you should make them aware of the consequences. But while we are doing that, at the same time, we as physicians should be very cautious of the way that we are addressing obesity, the kind of terms that we are using. We need not be judgmental. I may have a patient who's got 120 kgs, so I should not look at, oh my God, there's so much of weight. Maybe this patient had 140 kgs a few months ago, and the patient is already doing very well. So again, I need not be judgmental, but I have to be very, very cautious in the type of terms that I use with my patients. I shouldn't stigmatize obesity. And you should use the correct scientific terms. Very recently, we did a study in Vellore looking at what is the association of stigma with weight. And obviously, all of us know that people who are obese often are facing stigmatization in society, but the other way is also important. People who are stigmatized tend to have poor eating habits, higher depression, higher suicidal tendencies. So it's a vicious cycle. It's not only that obesity leads to stigma, stigma also adds on to the weight. And I think the first people to stop stigmatizing should be us as physicians, because we need to understand that this is something that's not good. So again, using obesity-friendly language is something very, very important in clinical practice. This is one article that we wrote a couple of years ago, talking of what we should do and what we shouldn't do when we manage obesity. But again, highlighting the first important thing that we need to do when we talk to patients with obesity is to try and find out whether they are willing to lose weight or not. That's the first A. It's pretty simple, but it's very, very important. The second A of the 5A framework is to assess. And I would say there are three things that we need to assess when we assess a patient with obesity. I think the first thing is to assess the severity of obesity. The second thing is to try and assess the root cause of obesity in that given patient. And the third thing to assess would be to assess the comorbidities associated with obesity. So first, let's talk about the severity of obesity. And there's several obesity indicators that are available in clinical practice. The most common one that we use is BMI. But yes, waist-related parameters have been shown to be better in the South Asian population, and more recently, wrist circumference, neck circumference are also coming up. Good longitudinal data from South Asian countries, again telling us that these are more easy to measure, culturally more easy rather than measuring the waist circumference where people are clad with different types of dresses, so it's difficult in practice. Obviously, the best would be to assess body fat, especially the visceral adipose tissue. So yes, when we talk of BMI, we have different cutoffs for the South Asian region that is given by WHO. And unlike in the West, where obesity is defined as BMI more than 30, for South Asians, for us in India and Sri Lanka, anything more than 25 kilograms per meter square is obesity, and then it's further classified as obesity grade 1, 2, and 3. But yes, over the years, we know that BMI is not the best indicator because we tend to have higher fat even at lower thresholds. So yes, waist circumference and waist-related parameters have been shown to be good. Several studies, including a paper from Kerala. But over the years, today, what the Western literature is also pointing out that BMI alone as an obesity indicator is probably not the best, and therefore we need to move on to something further on. Well, if given a choice, the best indicator for obesity would be visceral adipose tissue. In this particular study, where we are studying mother-daughter pairs and their respective metabolic comorbidities, the visceral adipose tissue, which was assessed by DEXA, seems to be the best. But how many DEXA scans do we have in our country? It's not definitely sufficient at this point to assess visceral adipose tissue for all patients with obesity. So what simple thing can we do? Well, very similar to our clinical practice in diabetes, where we assess eGFR. We don't really measure GFR, we just estimate it using a simple formula. We do it for all our patients to stage CKD. Very similar to that, we have formulas which are available that can estimate visceral fat fairly accurately, which has been validated in our population again. This is one such example called the METS-VF. It's a simple formula that uses clinical parameters as well as a few simple biochemical parameters and gives us a value of what the visceral fat should be. Well, if we don't want to get into formulas, we want to look at something even more simple. We can assess obesity even more simply, and this is something called the Edmonton Obesity Staging System, again endorsed by almost all recent guidelines, first published in August 2020 by the Canadian Obesity Network. It's a very simple staging tool, and I'll take you through it, how we use it. So irrespective of the BMI, any patient with obesity that walks into my clinic, I could give them a stage of 0, 1, 2, 3, or 4. And this would be based on the comorbidities that they have. I would assess them with respect to their medical comorbidities, their mental, and their functional status. So I may have a patient who's got a BMI of only, say, 29, but that lady has severe osteoarthritis of the knee. She's not even able to get out of the wheelchair. She comes to my clinic on a wheelchair. So for that patient, that even 29 BMI is quite a burden. I may have somebody who's got a BMI of 36, and that patient may have prediabetes. So because that is stage 1, because it has preclinical risk factors, a BMI of 41 may still be stage 1, but that lady with osteoarthritis of the knee with a much lower BMI would fit to stage 3. Now, how does this help? Is it better than BMI to stage them like this? Well, this was shown by an elegant study following up the NAINS database for over 15 years, and this is how you see the BMI predicts mortality over a period of 15 years, but how well the Edmonton obesity staging system tells us very clearly as to whether our patient is going to survive or not. And today we also have guidelines which tell us at what Edmonton obesity stage system, what kind of treatment we have to start, where we need to start medical therapy, where we need to intervene with intragastric procedures, where bariatric surgery is required, where only lifestyle would suffice. So this is not based on BMI, but based on a simple staging system. When we looked at data from Velo, we found that a significant number of patients do actually belong to stage 2 and 3. That's about 70% of the population that come to the obesity clinic there in Velo. So that was the first thing to assess. The first thing to assess was to assess the severity of obesity. We have all the anthropometric indicators that we can do. The best one would be to assess fat. Even if not assessed directly, we can estimate it. But even something more simple would be to look at a staging system as the one that I showed. The second important thing that we assess in patients with obesity is to try and assess the root cause of obesity. And there are different ways or different reasons why people have obesity, and believe me, it's not true that everybody is eating more and walking less. If it was so simple, it would have been easy to treat obesity, but that's not the case. And we need to try and find out in that given patient who's sitting in front of us, what is the root cause of obesity in that? Sometimes it could be just the genetics. Maybe everybody is having severe obesity in the family. Sometimes it could be certain medications. Patient may be taking steroids. Sometimes we don't even know that they are taking steroids. It might be just part of their some kind of native medication, some kind of powder that they may be taking. Could be related to depression, could be poor dietary choices, could be just poor knowledge of dietary choices. They may be thinking that this particular thing that they're taking is really healthy, but that may be very, very calorie dense. At the same time, sometimes there may be physical limitations with respect to somebody with osteoarthritis who cannot do exercise. So obviously we need to try and find out. And the best way to find out the root cause of obesity in a given patient is to try and just go through the routine of a patient from right in the morning, what time they get up, till the time they go to the bed. What time they wake up, what do they have in the morning, whether it's morning tea, whether it's with biscuit, which biscuit do they take, what time they have their breakfast, how many times they skip the meal, what time they go to office, what kind of lunch they get, do they get it from home, everything, just everything that you ask them, right from frequency of eating out to frequency of ordering food home, the quantum of oil intake, everything. Once you go through a routine day of a patient, you do find out a lot of caveats that you can address. So that's the second thing you need to assess, the root cause of obesity in a given patient. The third thing that you need to assess is to try and assess the comorbidities associated with obesity. And this is the simple 4M framework. Again, I think as physicians, we all do a wonderful job to assess the metabolic problems. But what we often miss in clinical practice to also look at the mental and the mechanical problems. And these are equally important. Again, when we looked at literature from our own clinic, we found that about 30% of people who walk into our obesity clinic actually have an underlying psychological problem that needs addressal. And most common of that would be depression. So yes, that is something also important. So it's not only just the metabolic problems, but also the mental and the mechanical problems like osteoarthritis, obstructive sleep apnea. All of that also needs to be addressed in a patient with obesity. So that takes us to the third A. The first A was asking whether a patient is willing to lose weight. The second A was assessment, assessing the severity of obesity, assessing the root cause of obesity, and assessing the comorbidities associated with obesity. And the third is giving advice, and I would say this is the most important A in the 5A framework. So what advice should we give our patients? Obviously, a general advice that is helpful in terms of sleep, time management. Adequate sleep is something very, very important. Anybody sleeping less than 7 hours has an odds of 2.5 of developing obesity, so good sleep is important. Dietary interventions are important, and patients come with a lot of questions in practice as to what kind of diet should they be taking when they have obesity. I mean, there's a whole plethora of number of diets that are available. But by and large, if you look at all the diets that are available today, it could be classified into two. It could be classified as those which are calorie restriction diets. So it could be simple like intermittent fasting. So it's nothing but calorie restriction. Or it could be a diet which is change in macronutrient composition. So you may be having a lot of fat. So that will be called as keto diet. Sometimes it would be high protein diet. Sometimes it would be a low carb diet. But by and large, if you look at literature and follow-up, and more recent meta-analysis, even for follow-up of 5 years, the bottom line is whatever diet that works for weight loss doesn't depend on calorie or macronutrient change. The ultimate thing is how well the patient can sustain it. Otherwise, it's all the same. A patient with keto diet may lose 15 kgs today in 6 months, but if the moment the patient stops it, there will be a weight regain. And in 5 years follow-up, you would see how bad the rebound can be. So what is really important when you prescribe diet in patients with obesity is that it should be a patient-centric diet. You try and understand what kind of diet is usually followed in their home based on their practice. And once you know that kind of a diet, you can probably, the first thing that you can suggest is just change the proportions of the food that is usually cooked. If it is dal and rice, maybe have more dal and less rice. That's something easy to follow. If you get a whole new diet, maybe some patients would be willing to follow, but how long would they follow that? And that's something that has to be done. So it's a patient-centric approach when we talk of dietary approaches. All literature which is available for all fancy diets that are available, the ultimate way in which they lose weight is through calorie restriction, and more important is the sustenance. We came up with this consensus a couple of years ago. Dr. Noel is part of it from Sri Lanka. And I think if one line that I have to mention in this entire 30-page consensus that is available for nutrition in diabetes and obesity is to make sure that our patients eat adequate amount of protein. I'm not saying high protein, just to meet up the normal recommended amount of protein, which is 1 gram per kilogram per day. And if we are able to meet that much amount of protein, that it helps in weight loss, because that amount of protein is going to give the patient a lot of satiety, and that amount of protein will ensure that when it is broken down, it uses a lot of energy. So that is the most important thing. Again, when we looked at data from our clinic in Velo, we found that even these patients who are all having morbid obesity, BMI more than 35, and they're consuming a lot of calories, they're still not able to meet the normal requirement of protein in their diet. So I think the most important thing in diet would be protein. Apart from that, more recent concepts talking about dietary fiber, that's also something which is very helpful in weight loss, at least in patients with diabetes, to give the recommended amount of fiber that is required. And again, several studies, and this is one longitudinal study that we were involved in, again, talking about how fiber is important. But apart from macronutrients, more recent literature today talks about also the micronutrients that are very important in obesity. It's just not about carbohydrate, protein, and fat. More recent studies also tell us importance of folate, importance of B12 in having to do with weight loss. So there's a lot of dietary interventions that we can talk about. It could be probably a day-long lecture, but the bottom line is our patient should get a person-centric approach for diet management. Gone are the days that you have a pamphlet for obesity, that this is the do's and don'ts, and you expect that to work for all patients. No, it will not work in the long run. We need to centralize it for a given patient. The third important thing is physical activity. And again, if you understand or ask our patients to just understand the mismatch of kind of physical activity that they require to burn simple or commonly available foods, which is something very commonly most of our patients would be eating, an average serving size of French fries. How much exercise is required to burn that? Well, if we just look at the amount of walking, requires 3 hours, 13 minutes of walk to burn 1 medium size of French fries. So I think getting our patients to understand this mathematics is very helpful, because then they understand that just half an hour of gymming is probably not giving them the license to eat anything and everything under the sun at that given point. So they need to understand how much calories they require to burn for eating simple things. So that's important, but at the same time, it's important not to leave our patients with all the exercises on day one. It's a stepwise process. We start with simple flexibility enhancement, go on to balance training, aerobic, and resistance exercise. As I mentioned before, psychiatry plays a very, very important role in management of obesity. In our pediatric clinic, we have a psychiatrist in place getting a good kind of a behavioral therapy. The intensive behavioral therapy is something also that is very, very effective and requires attention. Talking briefly about meal replacements, this is a concept. What is the concept of meal replacements? Essentially, you ask the patient to skip 1 or 2 meals in the day, and that would be partial meal replacement, and give a pre-packed meal from the pharmacy, which can be sometimes very expensive, but sometimes can be, if your dietitian is good, they can make from homemade products a kind of a meal replacement. The whole concept is that you're going to give very low calorie, maybe about 150 to 200 calories in a meal with 20 grams protein. But the advantage is that the commercially packed meal replacements take care of all the micronutrients that are required for a given patient. If the patient is just on a very strict dieting of taking 200 calories in a meal, at the end of 1 month, they'll come back to you and say, doctor, I'm losing hair, my nails have become brittle, I think my memory is gone. So if the micronutrients are well taken care of, and they take only 150 to 200 calories in a meal. In the US, they follow complete meal replacement. They give all the 4 meals replaced 900 calories. Patient lose 20 kgs in 6 months, but that's probably not very feasible in our part of the world, where partial meal replacements do give good results, weight loss to the scale of 7 to 10 kgs. Again, endorsed by the Western guidelines, literature now available with large number of patients, and follow-up data available for 3 years, and also endorsed by the Endocrine Society of India. But then, yes, there are specific indications. When my patient comes and says, doctor, I stay in the hostel, I have to depend on the mess food, and I really cannot change the kind of diet that you're suggesting, something like meal replacement would be helpful for that patient because they can not really change their diet when they're eating from a mess. Moving on to medications, and things have really changed. But before we talk of anti-obesity medications, I think what is really important is to try and understand that the medications that the patient is taking for comorbidities, that needs to be looked into in more detail. Even for something like diabetes, there are drugs that increase weight, there are drugs that are weight neutral, and there are drugs that reduce weight. So even if you cannot give the weight-losing drugs, at least make sure that they are on weight-neutral drugs, not sulfonylureas and insulin if it's not required. If it can be cut, it's helpful because that will also contribute to weight loss. Not only for diabetes, for every possible comorbidity, be it depression, hypertension, oral contraceptives, anti-seizure medications. Again, any medication that is causing weight gain should be looked into carefully. Apart from that, overall, the anti-obesity medications have been very sparse. I think in Sri Lanka also what we have is only orlistat and liraglutide, which is just 0.6 and 1.2 and 1.8 milligrams. Again, the cost for these medicines is a concern, but new medications are coming, which was initially only for diabetes, but now also for obesity. Just briefly mention the ones which are really there and look very promising. Semaglutide has been approved by the US FDA, even in the Indian scenario, once a week injectable semaglutide, causing weight loss to the scale of 15 kilograms or 15%. Another drug, tirzepatide, which is indeed not only a GLP-1 RA, but also a GIP agonist, causing weight loss to the scale of 21%. Now, this is something which is reaching very close to even sleeve gastrectomy. Another drug, which is a combination of an amylin analog and semaglutide, called CagriSema. This is another drug that has shown significant weight loss. And if you've attended any of the ADA meetings in the last 6 months, the American Diabetes Association conference in the US in June had all presentations with respect to so many anti-obesity medications. And if there's one drug that I'd really highlight, which has really shown so much weight loss, is not only a GLP-1 RA, not only a GLP plus GIP, but also a glucagon receptor agonist, a triple agonist, retatrutide, which has shown 22.4% weight loss in patients in the phase 2 trials. Phase 3 trials are ongoing. We at Vellore are doing them, and I think this drug is really promising. But obviously, they will be very expensive. They'll take time to come. The future of anti-obesity medications looks very, very bright. Apart from that, talking about bariatric surgery, yes, I would say that's the most effective, I would say the king of management of obesity at this point in time. Yes, the South Asian guidelines are again having a little lower threshold, the BMI cutoffs, little lower than the West, so if the BMI is more than 37.5, without comorbidities, and 32.5 with comorbidities, bariatric surgery can be recommended. But I think what is really important is to understand the contraindications. If somebody's got a reduced life expectancy, psychotic disorders, active substance abuse, we wouldn't like to offer them bariatric surgery. Intragastric procedures are also something helpful. I've had patients from Sri Lanka come to Vellore for these procedures. They've done extremely well. Again, 15 to 20 kilograms of weight loss that can happen with these procedures, and after that they need to be on a weight maintenance diet, which is again helpful in maintaining their weight. So I think that was the third A that we were talking about. We've talked about ask, assess, and advise. The fourth A, which is important, is to called agree. And whatever plan for obesity management that we're giving to our patients should agree to the plan. And this is something important because it's not you who has to follow all these instructions. Our patient should be agreeable to the plan that you're offering. Again, this is something which is a patient-centric approach rather than a doctor-centric approach. Give the patient SMART goals which are achievable. So if I say, okay, if you are able to improve your glucose levels to this much, reduce your weight to this much, maybe I'll stop one of these medications. So patient will really work towards it and coming back with a positive result. And I would say the fifth A is also one of the most important A's, which is called assist. The whole concept being that today we treat obesity like a chronic disease, like diabetes. So if I have a patient with diabetes diagnosed today with an HbA1c of 11, I would start on medications. And 3 months down the line, if my patient is doing well, A1C is less than 7, that doesn't mean I stop medicines. That means I continue those medicines and I continue them lifelong. And very similar is the management of obesity. Today, when we talk about it being a chronic disease, assistance is important. It is really important to follow up these patients, and follow-up is required lifelong. And that is something that will help to make sure that these patients maintain the weight loss that they have achieved in the initial years. Because if they lose follow-up, they come back to you after 2 years, they would have regained because there hasn't been a check every time. And our metabolic set point keeps changing, and therefore these patients can have weight regain. So this was the simple 5A framework I thought I could present, which could help us managing patients with obesity in our day-to-day clinical practice. The key points that I'd like to summarize are that, yes, obesity is a big problem, pandemic proportions globally, and in South Asian countries like ours. The guidelines have changed over the years. What used to be a BMI-centric approach today is more of complication-centric approach. Today, we no longer just assess obesity looking at BMI, but again, looking at more comprehensive staging systems which have better predictability for mortality, better treatment options based on these stages. The 5A framework that I suggested has been suggested initially by the Canadian Obesity Network is something which is easy to follow, can be done routinely in our clinical practice. We have to be aware of the newer methods and the newer modalities of treatment that are available, not only in terms of meal replacements, the surgical procedures, but even the medical procedures, medical drugs that are coming in the pipeline, because they seem to be really promising. So with this, I think I would stop here. I'd like to thank and acknowledge our team way back in Vellore, who works with the help of which we've done some of the work. Thank you so much.
Zydus, affordability with quality for diabetes management.